Hello Medicos and welcome back to my channel once again. If you think this video is informative, then please like it, share it with your friends and subscribe to my channel. Don't forget to hit the bell icon so you are the first one to get notified as soon as I upload the video. So today let's discuss VKC. VKC is Vernal Keratoconjunctivitis. It is otherwise called as the spring catarrh. Is it a misnomer? Yes, spring catarrh seems to be a misnomer because we see that VKC is more common in summers and recently we are labeling it as warm weather conjunctivitis. So what is vernal keratoconjunctivitis? It is nothing but it is a recurrent, bilateral, interstitial, self-limiting, allergic inflammation of conjunctiva which has a periodic seasonal incidence. Okay, so it affects both the eyes, right? And it is recurrent as well. Now, what is the etiology? As you can see here, the etiology is hypersensitivity reaction to an exogenous allergen. Could be a grass pollen or any other allergen. So, it was thought to be an atopic allergic disorder in many cases. So, what is the mechanism of the atopy? It is IgE mediated. Okay. IgE mediated mechanism plays a very important role. If you ask for the personal history, then the patient might also give you a previous history or a family history of other atopic diseases like what? Like hay fever, asthma or eczema. Peripheral blood shows eosinophilia and increased serum IgE levels, right? So what are the predisposing factors? If you consider the age and the sex, it is more common in age group of 4 to 20 years and in males, right? And the season, as I already told you, it is more common in summers. Which climate is it more common in? It is more common in the tropics, right? And less in the temperate. And you can see it is non-existent in the cold. Now, what is the pathology of VKC? This is really important. You already know that the conjunctiva consists of 3 layers. The histological layers are, the first is the epithelium, then you have the adenoid layer and then you have the fibrous layer, right? So what changes do you see in the epithelium of the conjunctiva? The conjunctival epithelium will undergo hyperplasia and will send downward projections into the subepithelial tissue, right? How about the adenoid layer? In the adenoid layer, you'll see that there's marked cellular infiltration by eosinophils, plasma cells, lymphocytes and the histiocytes, right? How about the fibrous layer? The fibrous layer proliferates and later it undergoes the hyaline changes. What happens to the conjunctival vessels then? It shows proliferation and there will be increased permeability and vasodilation. So because of all these changes, it will lead to the formation of multiple papillae in the upper tarsal conjunctiva. Okay, so this is the histological picture here. What is the clinical picture? So if you consider clinical picture, the first thing you should know is because it is an allergic disorder, it is often self-limiting. Coming to the symptoms, spring catarrh is characterized by marked burning and itching sensation. Now this becomes slowly intolerable and is accentuated when the patient comes in warm, humid atmosphere. Itching is more marked in the palpebral form of disease. We'll shortly learn about the different forms of VKC. So in the palpebral form, you'll have more of itching. Then what are the other associated symptoms? You'll see that there is mild photophobia, lacrimation, stringy ropey discharge and heaviness of the lids. Okay. So it burns out spontaneously after 5 to 10 years. What are the signs now? There are 3 clinical forms. The first type is palpebral form. What happens in the palpebral form? Usually the upper tarsal conjunctiva of both the eyes will be involved. What are the typical lesions here? You can see that it is hard flat top papillae arranged in cobblestone appearance, also called as pavement stone fashion, right? What happens in severe cases is these papillae get hypertrophied and they'll produce cauliflower-like excrescences of giant papilla. And the conjunctival changes are always associated with white ropey discharge. Okay. Coming to the next form. The next form is the bulbar form. Bulbar form is characterized by dusky red triangular congestion, where in the bulbar conjunctiva of palpebral area. Right. Then you'll see there is gelatinous thickened accumulation of tissue around the limbus. And after that, you can also see that there are presence of discrete white raised dots along the limbus. These are nothing but these are the Trantas spots. The third type is your mixed form. What is the mixed form? See, Trantas spots. You can spot over here the raised white dots. Okay. So coming to the mixed form. In the mixed form, you'll see features of both the bulbar form as well as the palpebral form. Right. So what are Trantas spots? Trantas spots are discrete whitish raised dots along the limbus. Okay. Now coming to the corneal involvement. The vernal keratopathy is due to the extension of limbus, the limbal lesions. Okay, so it is basically of 5 types. The first is your punctate epithelial keratitis. It involves the upper cornea. Okay, and is usually associated with palpebral form of disease. This lesion is always stained with rose bengal and invariably with fluorescein dye. The second form is the ulcerative vernal keratitis. What is the characteristic of this type of lesion is shield ulceration. These shield ulcers are otherwise called as your Tokbai ulcers. Okay. So what are these? These are shallow transverse ulcers in the upper part of the cornea. The ulceration is due to the epithelial macro lesions. Okay, the macro erosions that are happening in the epithelium of cornea will give rise to the ulcerations. Okay, so is it a serious problem? Yes, it is a serious problem. Why? Because it is complicated by bacterial keratitis. Okay, so the third type of lesion is your vernal corneal plaques. Why does this happen? It results due to coating of bare areas of epithelial macro erosions with a layer of altered exudates, right? Then what is subepithelial scarring? It occurs in the form of a ring scar. What is pseudogerontoxon? It is the classical Cupid's bow line of VKC. Okay. Now, see, this is the artist's diagram of mixed form of VKC. You can see the cobblestone papillae over here, the gelatinous limbal membrane. These are the white raised Trantas spots, the dusky red triangular congestion, right? So it is a mixed form because bulbar form characteristics are over here and the palpebral form characteristics are here. So this is the artist's diagram of a mixed form of VKC. Now, what is the differential diagnosis? It should be differentiated from trachoma. Trachoma, that too with predominant papillary hypertrophy. Okay, coming to the treatment now. For the treatment, you have the local therapy, the systemic therapy, the treatment of the large papillae, general measures, desensitization and treatment of vernal keratopathy. First, we'll see the local therapy. Under the local therapy, we give topical steroids. How do you start the topical steroids? You will give fluoromethylone medrizone, betamethasone or dexamethasone. How? You'll start with 4th hourly for 2 days and then you'll follow it by 3 to 4 times for a day. 3 to 4 times per day. For how many weeks? 2 weeks. Right? Okay, so why do you use this? Because these are effective in all forms of spring catarrh. But always minimize the use of steroid because it can induce glaucoma. So steroid-induced glaucoma should be prevented, right? Therefore, what you do is you will always monitor intraocular pressure during the steroid therapy. Then what is the next one? The next is your mast cell stabilizers. What are the mast cell stabilizers? They are the sodium chromoglycolate, 2% drops. How do you give it? 4 to 5 times a day, especially in atopic cases, right? Coming to acetylcysteine now. Acetylcysteine has mucolytic properties. So, you will give 0.5% of acetylcysteine for the treatment in early plaque formations. Topical antihistaminics are also quite effective. How about topical cyclosporin? You can use in severe unresponsive cases. Okay. So what is the systemic therapy? In systemic therapy, you can either give oral antihistaminics or oral steroids. Antihistaminics will provide relief from itching in severe cases. How about the steroids? You should always give it for a short duration. And in advanced, very severe and non-responsive cases only. How do you treat the large papillae, the cobblestone papillae or the giant papillae? So the giant papillae, they are treated with either the supratarsal injection of long-acting steroid or the cryo application or surgical excision for extraordinarily large papillae. Coming to the general measures now. General measures are very similar to those you have seen in acute bacterial conjunctivitis, like the use of dark goggles and the cold compresses. Apart from this, in VKC, you see that you have to change the place from hot to cold area, in which cases? In recalcitrant cases. So the next mode is desensitization. Desensitization is under study and we'll see if the results are rewarding in future. How do you treat vernal keratopathy? Treatment of vernal keratopathy is based on which type is it. So if it is a punctate epithelial keratopathy, it does not require any extra treatment except that you will instill steroids more frequently. What if it is a very large vernal plaque? It will require a surgical excision by superficial keratectomy. Okay, superficial keratectomy. If the shield ulcer is very severe, then you will go for a surgical treatment, because a severe shield ulcer represents that it is resistant to medical therapy. So you can either do debridement, superficial keratectomy, excimer laser, therapeutic keratotomy, as well as amniotic membrane transplantation to enhance reepithelialization. So this is all about vernal keratoconjunctivitis. I hope the concept is clear. If you have any doubts, please let me know in the comment section. I'll try to clarify them. Thank you.